now we have one of John's great predecessors, the Secretary of Health of the state of Maryland, Meena Seshamani. Was also, I should say, the former Deputy Administrator of CMS, and it's great to have her here. Great to see you again. Thanks so much for joining us. Yes. Hi. Oh, I have you both. Excuse me. And Gloria Sachdev, Secretary of Health and Family Services for Indiana. Gloria, I'm so sorry.
No problem.
Good to see you. Great. Yeah, it's been a blur for me this morning. I know I'm going to walk out there at 5 o'clock when I've invited everybody for drinks, and I'm going to say, do you remember that? I'm not going to remember anything. But it's great to have you both here. We've got Indiana and Maryland. I'm a constituent in Maryland, in Chestertown, Maryland. So thank you very much for both your services. I kind of think about, this. I think one of the points of hubris, and you've worked in the federal government, is the federal government is the source of all things and done all things. And I'm really interested in the fact that states are innovation labs, and we're like thinking about bold bets today, way to shake up the system, way to get greater efficacy out of the clutter that a lot of people feel in healthcare. And if there is, I think Americans are anxious about a lot of stuff. They're clearly anxious about AI, even though I see AI as a tool for a lot of these opportunities. Mm-hmm. But they're also anxious about how they can afford healthcare, what options they have. They have hard kitchen table economic choices. And so, Madam Secretary, I just want to say, Meena, to start off here, within your realm, would love to get a snapshot of how Maryland is trying to sort of shake this up within your own arena, and we'll do the same with Indiana. So, Meena?
Great. Well, it's wonderful to be here, and I also want to say how glad I am to be sharing a couch with one of my fellow secretaries. And I think importantly, if you think about blue-red, like, I am also wearing blue. You're not wearing red.
I can wear red.
Can we borrow red?
I'll go get a
red scarf. Yeah, we get your red scarf.
But I think it's really.
He's got a red tie.
But I think it's really important because to some of what you were saying, I really think that states are that laboratory of innovation, and also we are where care happens, right? We are on the ground trying to solve problems for our communities, and I think that's common and is something that all of us are working through together, given all of the changes that are happening right now. So, in Maryland, one of the things that makes Maryland unique is our payment model. So Maryland is the only state in the country where hospital payments are aligned across all payers. So it doesn't matter if it's Medicaid, if it's Blue Cross Blue Shield, if it's United, if it's Medicare, for that provider, it's agnostic, which really then enables you to provide the right kind of care, because hospitals have a global budget under which they operate. So they get a set amount of money regardless of how many admissions they have. So the incentive really is to keep your community healthy, keep people out of the hospital, really drive quality metrics. And I think that ties into some of the things that you mentioned in terms of AI, in terms of population health, where we have the opportunity in Maryland to really align care in communities with care in the hospital and be able to leverage the dollars that are in the healthcare system in a unique way. And so, one example that I'll give is our rural health money. Right? Like we have all states.
And just for our audience, this is part of the HR1 tapestry that everybody's trying to figure out how to navigate, right? So just want to add that in there.
Yeah, so the Rural Health Transformation Program was part of HR1, giving money to states for transforming care in rural areas. So what we have been able to do is, first, with our unique payment model, we can take dollars that are in traditional healthcare and apply them towards traditional public health. So we are investing healthcare dollars in healthy food, in medically tailored meals, produce prescriptions in vulnerable communities. We then can leverage our rural health money to invest in food aggregators, food hubs, so money going to our local farmers so that when we're using healthcare dollars for healthy food, which we know is ultimately a smarter way to improve the health in our communities, we're then also enabling our local economies to be the ones to supply that food. So I think that's one of the things that's so great when you talk about the, states being a laboratory of innovation, that we are able to connect those dots in that way that enables us to really drive change, not just in traditional healthcare, not just in traditional public health, not just in traditional agriculture, but in the improvement of life for our communities.
Yeah, thank you for that. And Madam Secretary Gloria, I would love to hear how Indiana is approaching this. I mean, you've got, like Maryland, a huge amount of rural areas, but I just sort of think that the tapestry of approach is interesting and different. I'm also interested in how you're innovating in this space.
Well, thank you for inviting me. It's such an honor to be here with everyone today and to kind of share a couch with Meena. She got a great deal in Maryland in 1971 with this deal with CMS to do all payer rate setting. No other state has that, so congratulations, because they are able to kind of focus on using extra money because all the disincentives, the misaligned incentives have been removed. The rest of us, including Indiana, we don't have that.
So why is that?
Our commercial, why is that? So like Medicare pays a different rate. They pay, we'll just say 100%,
right.
Medicare. Medicaid has a different rate. And then the commercial rate is 3 times what Medicare pays, where in Maryland, everyone's paying the same. So what we've been trying to do now that we didn't have price transparency for, well, ever, So I led the first hospital price transparency study in the country with partnering with Rand Corporation. We did that a long time ago, and that was the first, and we keep doing it, iteratively. And what we found is, and it's commercial prices as a percent of Medicare. So imagine, we see a lot of variability. Some of the hospitals are charging 4, 5, 6, 700% of Medicare for the exact same service, while another may be charging 150, 200, 300% of Medicare. No difference in quality, high variability in price. So when we talk about affordability, it's a price problem. It's a price problem for us, and we've been I ran the Employers Forum of Indiana before I had this role. I've only been in government 15 months. It's been really interesting and a great learning experience. But when I was working with in the commercial space, employers are, and all of you, you work for an employer, I imagine, or work for yourself as an employer, you're paying a lot for health care. And sometimes you may go to a pharmacy and you're like, I want the GoodRx price, or I want the SilverScript price. And it's so much cheaper than your PBM drug price. And you're like, why is that? Why am I paying for insurance that is charging me so much more for a particular drug than if I just walk up to the counter and get it for free? And that happens with cash prices, with hospitals. So we really have to ask ourselves, and this is what we're doing. We have a litany of things that we've done, to help Hoosiers in Indiana. And then we are also doing a bunch of things to help employers in the state as well on the affordability issue. Happy to get into the, what our policies are. But
well, I want to tell people you were before this, you were president of the Employers Forum. My note told me you were dealing with these employers, and I do think it's out there. I don't think it's an even picture in there because we know some employers are providing health care, some are not. I mean, I think the area you're in is there. But when you're trying to find best and promising practices of what the North Star needs to be as you navigate these swirling currents, what are the key elements? I asked Meena the same thing, but what are the key elements that you need to do? And do employers get engaged with ideas of things they can see? Because employers at scale may see more of what's happening in the private market, what their people are experiencing, than maybe government officials.
It's a good question. Employers, even the biggest employers are all over the country, right? Like you can take any big employer, Microsoft, whatever. Any of these big employers are all over the country. Yeah. So they don't have a lot of negotiating power in any one state.
Right.
But if they're part of business coalitions, those are the ones that have been, the most successful. So, I ran a business coalition and we had a lot of employers. The biggest ones, medium ones, schools, cities, towns as well. What can they do? So, DC allergies. So, what can they do? direct-to-employer contracting has been really successful and really popular. The hospitals, providers love it. The insurance companies, maybe not so much.
Oh, you are so sweet.
So sweet.
Do you have a question or comment? I'm going to send the mic over to you. Okay, that'd be good. We'll get the mic for you in a second. Go ahead.
Thank you. What was I saying? Oh, yes, direct-to-employer contracting. So do you have to work with an insurance company, maybe for a wraparound service, but for orthopedics or for any particular line of service? We have a lot of employers, hundreds of employers doing direct-to-employer contracting. So much so that, and we found it to be so successful, we put it in statute.
Right.
We said every hospital has to offer an option of direct-to-employer contracting, less than 260% of Medicare. Now, it sounds like a lot. You're like 2.6 times what Medicare is paying, but that's just how outrageous the commercial side is. So, and they did it. We did an audit for the big five. They're complying, and all the rest of them have to do it by September of this year.
Right. Meena, we were both recently at a different conference, not called Bold Bets, but Big Bets in Baltimore. And
bold, big,
What's that?
Bold, big.
Oh,
it's all
bold,
bets,
big.
yeah.
We picked bold, they picked big. But I moderated the thing, and I had this fantastic hero of a guy. I cannot recall his name, but he was a community health, CEO of a community health hospital in this, and kind of looking at this, and it just reminded me of some of the disparities in care, and particularly even in the Baltimore area, very big gaps in life expectancy across zip codes or across railroad tracks or whatever. I'm just interested in the human side of this as we're kind of looking at, big systems of payments and reimbursements and doctor systems. How do we somehow also root it into changing the realities and the health stars of people who have just very clearly fallen out of the picture?
Yeah, well, I'm really glad you asked that, because I think at the end of the day, we can have these very, heady conversations about data and systems and payments, but it really all comes down to the people that we want to serve. Right. So I think it's really important that everything we talk about is grounded in the lived experiences of the people in our communities. And you can leverage the data and the infrastructure and the payments towards that goal. So I'll take the example that you gave about community health. I think that is really a key factor in how we can improve care for our communities, because we all know that 80% of what determines someone's health occurs outside of a hospitalization, or the four walls of a physician clinic. And so we in Maryland have been leveraging community health workers, for example. In fact, before I took my past 2 policy jobs, I ran community health for a major health system here in the DC area. And it's incredible. There was one woman who came into one of our EDs 17 times in 3 months for exacerbation of COPD, lung disease. We assigned a community health worker to her who went to her house, and the reason she kept coming in to the hospital was because her electricity kept getting shut off, so her nebulizer wasn't working. And so where you can find those avenues to be able to then, quite frankly, spend money in a smarter way, where you are keeping someone healthy, you're keeping them out of the hospital. And I think that underlies a lot of the affordability work that we are doing, in
the
states.
economics of it are just staggering, because I had never really understood that this person that I interviewed in the Baltimore conference, they have policy. They take care of every person who walks through the door, no matter what their insurance circumstances, no matter whether they're Medicaid, no matter what, where they are in the picture. And so it's very inspirational, but boy, I would never want his job, because, there's no way, I think fundamentally, unless you're kicking it down the road to get the economics of that to work. So as we're thinking about transforming healthcare and bold bets, I want to talk about bold bets for all parts of the game. And from both of your perspectives, how do we need to widen our aperture in a way that gets traction? It isn't just saying, oh, that's such a problem, but actually, to your point, we're beginning to see the needle move. And it's hard to be micro and win. You've got to figure out how to be macro with the micro. But
absolutely. Well, maybe I can start, and then Gloria, you should definitely speak to this as well. I think what you're saying is exactly right. Where you have that individual person, what is the system that enables that kind of intervention to happen? So Maryland, you happen to have 2 states that have very forward-leaning health information exchanges.
Right.
So Maryland has CRISP, where it is easy for people to see from the data what is going on in people's lives, including things like health-related social needs, so that you can then be able to say, okay, here are communities that need additional support. That's the data side. Then you have the payment side. So that example that I gave from when I was at MedStar Health, I then took with me when I ran Medicare. So now Medicare pays for community health services as part of a care plan, because to your point, it's wonderful, but there also needs to be a cash flow to enable that kind of care to happen. So how are you bridging the infrastructure so that those kinds of interventions can happen? And so in terms of bold bets, I would say for Maryland, our bold bet is number 1, having CRISP, which is an incredible source of data, actionable data that then can empower people in the system to be able to provide the kind of care they want. And number 2 is, to your point, having that bold bet of expanding our aperture, that we could sit and say, okay, health is about the doctor's office and about the hospital. And we all know that that is not going to solve the problems of health in our communities. And being able to say, no, actually, utilities, housing, transportation, food, those are all also very important. And that's a bold bet, because you are changing. I mean, I was only in medical school 5 years ago. No, I was, when I was in training decades ago, this was not what was talked about. Right? It is a culture shift but I think that is the imperative for all of us, because the path that we are on is not working.
Gloria?
I agree with everything Meena said. We also have a strong health information exchange, except for we have a lot of data. We have a lot of data, but we don't have a lot of information. And then we have to use that information, right, to create the changes. So one of the things that we're doing that's a bold bet for us is we're creating a medical center of operations, where across the state we'll be able to see like how many hospital beds are available, how full is the ED, where the ambulances are, so that we're not wasting time when someone's having a stroke or someone's having a heart attack, putting them in an ambulance and taking them to a place that can't accept them or doesn't have the skill set available. We've had some unfortunate cases where, a pregnant woman may have an emergency situation, but then the patient gets taken to a hospital that's not equipped to take care of her in an appropriate manner, and then there's a fatal
incident. There's a bed but no system.
There's a bed but no system. So this is a statewide system where we're going to coordinate care across the state. We want to do that for mental health as well. Again, it's a new bold bet. We've developed mobile crisis units and we're partnering with the state police. Again, with homelessness, they either go to jail or the ED. They even ask them that. Do you want to go to jail or you want to go to the emergency room? And neither one of those is the right answer, right? We can all agree it's just a rotation from jail and a rotation from the emergency room. So we are taking them now. We're going to go meet the cops where they're at and take them to an intake center. Oh, it sounds like my mic. Oh, maybe it was just me. Take them to an intake center, get them evaluated, and then see how we can help them. That intake center will get them over to mental health, substance use disorder, housing, and all those other social needs that are critical. And we really have to think outside the box here. One thing that I find that we can do a better job in is sometimes we'll provide one service or 2 services, but we don't provide all the services all at once. And so what happens then is you've provided a service, maybe some food service. You gave them food. Okay, that's great. You provided with them some mental health, but they need job training, and they need housing, and so you have to provide all the services all at once so that Medicaid for us becomes a trampoline so they can prosper. Not a fishnet where now they're just stuck in it for life. And so if we just trickle it out, that's what happens.
So in our last minute or so, just interesting, both of you. So, what I find is so interesting, John Brooks has a certain purview of a system here, and we've been talking a little bit if you are able to magically, through science, get some systemic positive impacts on the population, say in obesity or something, and then you begin looking at and you're able to maybe get other effects in the social ecosystem around that in ways you've just both discussed. The question is, does the system at the state level able to pivot and look and say, wow, we have a lot of cost savings here, now we need to prioritize here. I'm just interested in how the systems themselves can become smarter, take the inputs that are coming in. I feel like we're at an inflection point where maybe these opportunities, I always look at it, are we stuck in a world of inertia and small incrementalism, or do we get opportunities for strategic leaps? And I think, as Meena said, that in the states, you're gonna feel that before the federal government will, probably. Yeah. But I'm just wondering if I'm right. So quick form, am I right?
That's exactly what needs to happen. I have $32 billion underneath my belt, and we spend $2 billion on mental health. Right. And all these different agencies. And I'm like, which are the programs that work? Right? Like, which are the programs that work? Why are we just spending money out the door? So we are developing, and because again, you have to have the data. So we're developing a health and family services dashboard. It'll have all the contracts, because again, you can be smarter about how you contract if you know ahead of time that your contract is coming up. Not just when it expires, right? But then it'll have all the KPIs, all the patient outcomes associated with it. And then if funding gets cut from the federal government or a philanthropist or whoever for a particular program, we'll be able to quickly say, oh, CDC, this is all that's being funded. And, we'll have exit strategies.
Let me ask you the same, Meena.
Well, I just want to say ditto. But also,
there's never been so much blue state, red state.
Well, that's why this is honestly, we were both just at a 2-day meeting with 30 state HHS secretaries, and this is kind of the collaboration and conversations that you hear, to be totally honest. You mentioned the prior session with John Brooks. One of the things that I think you guys were ending on was cell and gene therapy. I think that gets to where there are those transformative changes, a step change in healthcare delivery, especially when you're talking about curing, a debilitating disease. And I think this is where that's a very good example of federal-state partnership, where we can fundamentally change the way in which a system is working to accommodate and encourage those kinds of transformative changes. The CMS is starting with sickle cell, but to come back to what Gloria was talking about, having come from the employer side, I think things like that are a call to action more generally for employers and health plans and providers to think about where there can be something that transformationally you change how you're engaging with each other. Because this is not taking a drug that you're gonna take for the rest of your life. This is taking a drug and then someone goes on to be working in society and think about the GDP production, and the economic effects of that, the avoided hospitalizations, right? And I think those present opportunities, sickle cell being one aspect, but we know CGT extends far beyond it, where I think there is a call to action to all of us to be able to partner in a different way. So
first thing I'm gonna do after this is done, after the 5 o'clock drink, so but I'm gonna send you both an email and they send you the date for next year. You have to come back. I think it's very inspiring to see what states can do across political. This is a town obsessed with political divides, and I think it's very interesting to hear both of you talking in such constructive ways about health. So Meena Seshamani, Secretary of Health of Maryland, Gloria Sachdev, Secretary of Health and Family Services in Indiana. Thank you both so much for joining us. And I hope you're back at 5 too. Thank you.
Thank you.